Question that we get a lot is, how do you know I'm not going to fatigue during an intensive week? A very valid question. Patients are used to having a low threshold and they're worried that that could be too much for them. What we do is we monitor our patients continuously during the intensive week, and we will most likely know before you do when we start to hit that fatigue point. Monitoring patients might look like having them wear a blood pressure cuff, a pulse ox, and we are watching you to see, is there something else? We've had patients that their eyes start to get droopy, their neck starts to get sweaty, their ears get flush, or they can tell, oh, I'm starting to dip. That's our point to take a step back and say, we have hit our threshold and there's no point in pushing you further, but we can get our activities in through different modalities. So we work with the 3 different principles of neuroplasticity, which are oxygen, stimulation, and fuel. The stimulation comes from the neurotherapy. The fuel and oxygen comes from different lifestyle modifications, dietary changes, as well as therapies we do in office, such as red and near infrared light, beamer, hyperbaric oxygen therapy. So we are working with all 3 of these to make sure that we are getting in the changes that we need. Patients usually have a low threshold, which is normal. What we work to do is use those principles of neuroplasticity to actually increase your threshold. When we do that, that's when we start to get an increase in the fatigue point. And as soon as we reach that, we take a break, increase the patient's threshold again, work back up to that fatigue point, and keep going like this so that we're never overdoing the fatigue point past the threshold where the patients are like, it's too much, I need to take a break. So we have a lot of different things that in our toolbox that we can use to monitor patients, but it depends on a case-by-case basis what monitoring looks like for you.